venture capitalist out in San Francisco. Our venture fund is extremely early stage companies. We invest in anything that would be pre-product, pre-market, but not pre-GTM strategy. One thing about me. I went to MBA school with Alberto Chan over there, who everyone knows. He seems like to be the most popular rock star of this conference. I really appreciate you inviting me here and meeting everyone here at Charles Morgan. I've always lived in Atlanta, Pittsburgh type places that are close to the Midwest, but not really Midwest. So being here in Cincinnati, getting to know people, the vibe is really beautiful. Nice. So thank you.
Yeah, thank you.
Sally Pace, and I'm the CEO of Connect Healthcare Collaboration. We're an employee benefits, engagement, and marketing firm that uses clinical advocacy to drive outcomes. We're based in Memphis, Tennessee, but our team is spread out across the country. And something that you don't know about me, unless you know me really well, is that my granddaddy was the welterweight champion and fought in Madison Square Garden, so you do not want to come up against me in a dark alley or a well-lit alley. Cody?
Man, that's a tough fun fact to follow. I'll start with the fun fact. I would say similar with me with the racket sport. I played tennis in college, so tennis especially, but anything with the racket I have fun and typically I'm pretty good at. My name is Cody Simmons. I'm the co-founder and CEO of DermaSensor. We just received FDA clearance and so have commercialized the first automated skin cancer diagnostic tool. And our focus is really frontline providers or primary care providers. And you'll be hearing more about that today.
Brooke Hupp. I am a regional sales director for MedBin. We are a third-party administrator. I've worked for them for 11 years. We manage a lot of Cheryl Morgan's clients, a lot of familiar faces out there. Something that you may not know about me, I'm a graduate of Ohio State University, and for my graduation present, I jumped out of a perfectly capable flying plane.
Good morning. I'm Mike Molyneux. I introduced myself yesterday, but I'm the president of Symbol Health Solutions. We're an on-site, we're a provider of on-site medical clinics. My previous life, I was trained as a physical therapist and somehow got into outsourcing hospitals, rehab departments in hospitals and outpatient clinics. And it turned into be a nationwide effort, nationwide company. We had a couple of thousand employees, probably 1,500 medical professionals working in 16 states. And then about 15 years ago, I started Symbol. It's very similar, the model, because really we're outsourced to employers. They're looking for someone to run their clinics for them. They're not our clinics. If I had my way about it, I wouldn't have a symbol on the sign anywhere. But my previous company was called TMS. There was never a TMS logo. There was never a TMS nameplate or embroidered on your white clinic jacket. And so we tried to blend in. So that's what I did before, and I was asked to sit on this panel talking about clinical products being introduced to the clinical setting.
Well, thank you, everybody. Thank you for being on the panel. When you think about new technology and being introduced, so that's what we're going to talk about. Cody's going to explain that, his technology. But being introduced to a population and making sure that that population is, accepts it and understands it, benefits from it. I think that's really the challenge of any new technology, right? And so we're going to talk as we go through our panel after Cody introduces his technology of how that can be introduced then to the population, to us as patients, and how it benefits us. Cody, take it away.
No pressure. All right. I'll share a bit more about what we've been working on actually for 9 years now. So very long an expensive $30 million in total went into R&D of what's a handheld, low-cost skin cancer diagnostic tool. It's my party trick. So it started off as a 30-pound microwave-sized device that we developed to the issued patents or license from Boston University. So they were our collaborators, and really our focus was helping improve the detection and management of skin cancer. Why skin cancer? It's more common than all other cancers combined. There's about 3 million Americans diagnosed each year, but it's effectively cured if detected early. 99% cure rate, early stage detection, even for melanoma, which is the most deadly. The challenge is there's about 100 million Americans at risk for skin cancer, but only 8% of them receive an annual skin exam. 15% have ever received a skin exam in their life. And even with that low compliance with the annual skin exams, dermatologists, as many people I'm sure are aware, are already overwhelmed. There's long wait times, major access issues. So how do you actually provide the recommended care for the other 90 million or so Americans? You can't do it with dermatologists, right? So the long-standing kind of public health solution to that was, kind of get frontline providers better at doing skin checks. It's like, well, that's hard because by definition, they're not specialists. They're not dermatologists. They didn't spend thousands of hours training in how to do that. But technically, it is within their scope of practice, right? Internal med, family med, OB-GYN, MPs at CVS Minute Clinics, right? Received at least a couple hours on how to assess skin conditions and, suspicious mole, ABCDs, there's certain basic clinical things. But studies show that they're missing about 3 times as much melanoma as dermatologists. And their number needed to refer, number needed biopsy, how many referrals or biopsies are they doing for every one melanoma is around 30 or 40 to 1. So it's like a 3% hit rate. Dermatologists like 4 times better than that. So that's kind of been the long-standing objective is like, can we improve their ability to effectively assess and manage lesions? And so 2 of our several published studies have shown the device is as accurate as an in-person dermatologist using whatever their tools are, standard of care, which is typically, it's called a dermatoscope. It's like a visualization tool. That we completed 15 studies in total. The pivotal study had over 1,000 patients, led by Mayo Clinic, 22 study centers. Just some quick top-line results. So the negative predictive value, depending on which study, is 97 to 99%. So that means when you get a negative result, it is negative 97 to 99% of the time, based on our published studies. 96% sensitivity for detecting all skin cancers. And when you get a positive result, it comes with a 1 to 10 scale, and the likelihood of malignancy in the pivotal study ranged from 6% to 61%. So you kind of get that immediate quantitative, relative risk result. And so that's, the innovation, and I think the product we're speaking about today, for the first time in America, in American healthcare, now when a patient sees their provider and says, hey, what do you think about this mole? Instead of the provider eyeballing it and kind of making their best guess, it can now actually be tested for skin cancer with a quantitative risk result. So it's been exciting. First device was shipped in May last year. We're already in use by about 500-600 providers at about 200 locations, including a few health systems. So that's, I think, kind of high-level recap on the product. It uses a type of optical spectroscopy. So it's a kind of probe tip touch to the lesion, pulses hundreds of different wavelengths of light into the skin, measuring the reflectance off the same things that pathologists look at under a microscope, like nucleus size, presence of condensed chromatin, things like that. And that's my background's biomedical engineering and also a business side. So know a bit about the technical, how to learn a lot about the clinical.
Yeah, thank you for that. When I first heard about this, I was thinking to myself, getting to a dermatologist is like one of the last things I like to do. I always put it off. And one of my chiropractors I used to go to, 45 years old, got skin cancer, was dead in 6 months. And you think about the effect that that has, being able to catch it early. So I was excited to hear, you know, that this can happen like at a physician's office. So for me, because I'm like the last gonna go and get things done. I mean, I'm a guy, typical guy, you know. And so,
and that's not being sexist. That studies show actually
right,
that women are much better at detecting
Yeah.
self-monitoring, and actually, I think that they detect more skin cancer on their partners and family than those men do on themselves.
Yeah.
So,
I can see that. Men are good for nothing. That's true. Yeah. Well, Brooke, as the third-party administrator, you know, you're the end result as far as getting the claim in. So, do you see obstacles, or do you see how it could be introduced? How you guys could take it in and function it? We talked about how this, you know, we saw this like as, you know, from a wellness standpoint, how it could really be effective. How do you see it? How would you guys take it in?
Yeah, so being a third-party administrator, managing self-funded health groups, the beauty is if an employer wants to cover this device and pay for it, that's completely up to you. But going back to, like, from a wellness standpoint, I think it's awesome. I know there's people in the crowd that have been affected by skin cancer, and just like you said, it's like the last thing that people are wanting to do, and this reminds me I probably need to call my dermatologist and get an appointment, and then it's going to be, you know, 3 or 4 months. So if this is something that, you know, employers can pay for their people, I think it's great. But what we're doing for our groups is making sure that this makes financial sense. Being a fiduciary to your plan, you're obviously going to want to pay for things that are necessary. So when a claim comes through, my first I guess thought is it coded properly? You know, are there CPT or HCPCS codes that are available for the device? So that's number one. But then also from a fiduciary standpoint, all of our claims run through basically what we call like an AI generated system. So they're looking for things that don't make sense financially or clinically. So is this something that could be flagged as medically not necessary or experimental? And if that's the case, then we would come back to the employer and say, how do you want to cover this? Or on the flip side, if this is something that you just want to add into your health plan, from a wellness perspective, that's great. We would just need to know through each employer, you know, what your thoughts are and how you want to cover it. I think it's a great device. I think that it can really help, but from a fiduciary standpoint, you know, how much is it going to cost? Are stop-loss carriers going to be asking about it or flagging it? You know, is it something that is going to cost so much that it's going to hit an employer's specific deductible? I don't think it's that expensive, but that's where, you know, we would have to get stop-loss input into how the claim would be managed. But other than that, from an employer perspective, you know, if it's not a situation that's going to hit your specific deductible and you're self-funded, you can do whatever you want from your health plan standpoint, you know, as long as it's approved internally, but, you know, you can cover the device however you would like. So going back, so making sure that there's proper codes, making sure that it's medically necessary and not deemed experimental. If it is, it could be flagged. That could potentially cause an issue. And then from a wellness perspective, if employers want to cover it, great. We just need to know how to code it internally to get that through.
That's really good feedback, because that's really the end result is can it be taken in from a claim standpoint and processed and really be managed from that standpoint. But now when you think about it from that physician side, that front line side, Mike, that sort of is your bailiwick. And so how does it, like, how can it be introduced from your side? And what's your thoughts on it?
That's a good question. It's sort of like, well, we'll only hire you if you have 3 years worth of experience. So how do you get the 3 years worth of experience if you have no experience with it, right? So that's the first little minor obstacle that you have to overcome in not having a long history of doing it. Over the years I've had, I can't tell you the number of similar situations. Some have succeeded and some have failed. People, entrepreneurs coming up with medical devices they think would help. I remember one years ago where it was a traction device for people with low back pain, and it looked like a pair of crutches. It grabbed you here and then up under your arms, and you would ratchet it down and you would walk around with it. It was like having traction, 24 hours a day, and increased the disc space, which is what it did. He ended up not going through medical billing and went on a QVC or something and made a short hit, and that was the end of that one. There was another one. The guy came in with a McKesson salesman one day, and he had a guy that was with him, and he wasn't really saying much, but he had this little bottle of toothpicks, and he kept shaking them the whole time. And I'm sitting there talking to Jack, and the guy over there and sitting over in the other chair, he's shaking his bottle of toothpicks. So we're getting ready to, in the meeting, finally I said, look, man, so what's up with the toothpicks? He goes, well, these are cinnamon-flavored, nicotine-laced toothpicks. And they're meant as an aid to stop smoking. And, I said, oh, man, that sounds really good. Hand-mouth situation, the nicotine burst. And so we put those in the clinics, and they never got the insurance reimbursement that he was looking for. And of course, all of our clients are self-funded, and they could have made that decision. So that's going to be a big part of it. Another thing is we discussed it very briefly just before we came up, is something called the NNT. Anybody heard of an NNT? NNT is called the number needed to treat. And so it's the number of people that you'd have to treat in order to prevent one adverse reaction. And I can't remember these numbers off the top of my head, so excuse me for doing this. I'm going to give you some examples. So for blood pressure medicine, to prevent one cardiovascular death, you'd have to treat 125 people. So the NNT for blood pressure medicine for that condition is 125. To prevent one heart attack, you'd have to have 100 people on. You'd have to have 100 people on antihypertensives. Statins, prevent one cardiovascular death, you'd have to have 83 people treated to prevent one person. So the cursory research I did on dermacensory is much, much lower. I think it's somewhere around 11. And it's really good about picking up if you don't have a melanoma. It's got a very high specificity rate. And its sensitivity, I'm not really sure what the number is. I'm sure you know.
Depending on which study, but 96 and 97% in
So
the
if,
two
it
big
says,
validations.
so if it says you have melanoma, you have a melanoma. And I understand that it's also been able to reduce the number of missed calls by 50%.
Yeah, cut missed cancers in half in our
Yeah.
pivotal study.
The problem is in a primary care practice, not a problem, but an issue I think would be, is, we see a lot of people don't normally come to their primary care doctor for, what they think might be skin cancer. And so we'd have to do a lot of them. So it would be a proactive, do you have any areas on your skin of concern?
Perfectly said. Yeah, we see a lot of customers, they'll add to their intake form, like, do you have a mole or skin growth you want the doctor to look at today? Or while taking vitals, the MA could ask that question.
Yeah, or just that you might see one. So I think, and going through self-funded plans is going to be a lot easier than going to a Blue Cross and trying to get them to cover. I mean, it would be almost impossible. So it's an excellent entree for your product. So that's what I think. So you've had some challenges, but I think you're probably heading in the right direction, going towards employer-based clinics and self-funded plans.
I'm glad you think so. That's why we're here. We hope so. Alberto said it would be.
You know, the big thing is you've got to get the person who you're selling it to. You got to get them to believe. You got to believe in the product.
Yeah.
You got to believe there's something worthwhile to it, because that's half the battle. You know. So.
Yeah, nice. Thank you, Mike. Appreciate that. This is good feedback, right? I mean, obviously, that's awesome. Because really, that's what we want to do. We want to be able to get it into physicians' hands so that they can use it, know how to use it, and are effective in that utilization. But really so that's sort of into your field, Sally. I mean, utilization and making sure that it gets used. And so what's your feedback?
Yeah, well, thank you for teeing that up perfectly, because yes, and you all know this, you can have the best solution on the planet, but unless it's utilized, it doesn't matter, and you're not getting the ROI that you've promised. And Cody, you know, I know this feels, I can't imagine, you're in the hot seat. For sure, but you're also not alone. So I'm gonna ask for a little bit of audience participation as we go through this. How many of you are a point solution, something that's being put into the plan? Raise your hand. Raise your hand. Hi, okay, great. You're up against this statistic. A recent survey shows that 68% of all employers feel that their benefits are underutilized. The offering that they give to their employees is underutilized. Okay, flip side, how many of you are employers, consultants, TPAs? Raise your hand. Hi, raise them high. Be proud of what you do. Okay, well, your statistic is that only 12% of the US population is healthcare literate or health literate, which means that even if they knew about the solutions being built into their plan, they wouldn't necessarily know how to navigate it. So this is where we marry marketing principles with clinical outreach to really turn those statistics on their head. So we do two things. So even if you don't have access to a big clinical outreach team, there are two things you can do. First is to deploy what's called the Rule of 7. Has anybody heard of it? Thank you. So in marketing, there's this statistic that says you have to tell somebody something 7 times before they ever understand it and take action. It's about the 4th or 5th time that people even start to pay attention. It's subliminal. Think about how Coca-Cola and Pepsi advertise to us. You're going to have to do the same thing. And so when you're put into a plan, putting information out, sending one flyer, being in the open enrollment guide will never cut it, because you're not even coming close to getting people's attention. The second is basic journalism principles. And again, Cody, I'm talking to you, but I'm really talking to all of you in the room who are trying to change the plan design, trying to change the lives that you're serving. So the basic journalism outline is who, what, when, where, why, and how. I'll send it to you later, because you don't need to be taking notes up here, but y'all should. And sorry, I'm the daughter of an educator, so I come by telling people what to do naturally. So, and it doesn't have to be in this order. But when you're telling people these things 7 times, you're going to say, who needs to know about it? And I know everyone has heard that personalization and benefits is real. So not everybody necessarily needs to know about it, but who does? And how are you going to reach them? What are you offering, or what is your solution? When is it needed? Where can I access it? There's possibility that you're going to be layered into an on-site, near-site clinic or another provider. So I need to know, where can I access it? When is it needed? Why do I even need it? And how do I use it? So I'm assuming I don't get to use that, but the doc, and it might be scary for somebody to come at me with this thing. So explain to me, how is it used? So if you tell members about this often and with consistent messaging, then you're going to be able to live out the ROI that you've promised.
That's so helpful. Because I mean, I think that's the key, is being able to get it utilized, and members to be able to feel like they're coming across or coming back with something. They're getting results, good or bad. You know, we don't want bad results, but we want to be able to have an answer to whatever we're dealing with, and I think that's really important. Now, word to you, Vineet. So, you think about this discussion. So what's your feedback? Your thoughts?
Yeah. So, where do I go with this? So as a venture capitalist, we're always looking at companies that are successful companies, because if they're not successful, then the impact is minimal, right? And so not only are we looking for returns, we're also looking for companies that can make a big impact. So in screening technologies such as this, like some of the bigger, we shy away from screening technologies, at least we have until now, because it's been tough to find startups that are VC backable, that can give us that high risk, high reward type of profile in this asset class. It could still be a great company, it could still be a great business, but very rarely does it fit our model. But that said, we're still going to look for it, and things are changing now. Digital health is more accepted. Physicians are now in a different generation, are more easy to adopt technology than before. That said, the 1 to 7 rule for physicians, I would make that 1 to 20, because we know there definitely should be some research out here, but the more qualified people are, the tougher it is for them to change their habits. But let me take a step back. So whenever we see a company like this, we not only meet with the founder, we go through a phase of due diligence where it generally takes us 2 to 4 months to kind of validate all aspects of this company. So we essentially go talk to TPAs, we go talk to physicians, we go talk to maybe even patients in this case, to try to understand the journey of the patient. In screening technologies, the earlier you can get into the journey of the patient, the better it is, right? And so where does the journey in this particular case start? I'm assuming it's at home. And then from home, it's to the PCP. From PCP, it's to the dermatology specialist. And there have been other technologies that are mobile device technologies that can do at least the ABCDE of dermatology, which is, correct me here, but I think A stands for...
I got you. Asymmetric, is it asymmetric, irregular border, irregular color, diameter 6 millimeters or greater, and then E is it evolving, is it changing over time?
Right, so lots of those other technologies that are just mobile device technologies do something like that very well. So what DermaSensor would have to prove is where they fall short is where you can fill that gap, and that gap is actually really meaningful. But to my prior point, we would actually talk to physicians to see if they would really change their habits or not. I think yesterday it was Rashid who said that a physician has to take 20,000 decisions before to get to the next stage of conversation. There are 100 other screening technologies being marketed to PCPs, right? And sometimes the easiest tests to get through those 20,000 decisions are the best ones. So would they really adopt a special kind of product here to just do the DermaSensor test, or would they still go back to their training, which is, I got to get through these 20,000 decisions, so maybe the ABCD visual test works better. So we're looking into things like that. I really like the who, what, where kind of framework. I think someone's recording it. I'm definitely copying it. But we use something similar at the next level, which is, who is your early adopter, right? Not all PCPs would adopt it. There's big PCPs, small PCPs, geographies, countries are different. Even within the PCPs, who's running the clinics have a different profile of technology adoptability. In this particular case, I feel there needs to be a tight payer provider combo here, because while the provider needs to use the device, it's the payer who's probably benefiting from it. And so the tighter you can get those, like integrative healthcare systems, Kaiser, Highmark Health, UPMC, those are great. But if you could get even tighter, which is like self-insured employers, right, where the economics are all front and center, that might be even better. And SIEs where the clinics are in-house, on-prem, those are probably even better. So who are the early adopters? We look for the startup to educate us on that. The more the founder can educate us on that, the more they're not just the founder, they're also the CEO, right? What do you tell when you meet these people? So you have to educate the doctor or the people using it. So not only do you have to provide them a great amount of data on the specificity, sensitivity, etc., but you have to educate them multiple times in multiple different venues, probably more than 7 times. How many of them are out there? That's more market sizing, so that gives us our returns. And then I'm missing a few. Oh, and how do you get to them, which is also more like a marketing sales kind of play. But we look at all of that over those 2 to 4 months to kind of understand how viable is this technology. I do know that DermaSensor is already has narrowed down working with SIEs, and that's a great step. And we would probably look for that data, and we would look for how well it could be used to educate physicians, probably put it in front of some physicians to see how quickly they would change their habits, and that would be a good, strong indicator for us, albeit soft indicator, but strong.
Yeah, that's helpful. Any thoughts?
Yeah,
comments?
I'll add a couple quick comments, which we benefited greatly. You know, a lot of this ends up being about kind of luck from a timing standpoint. A couple companies spent tons of money, I mean, tens of millions of dollars on technology development like we did, but also then, I mean, 50 to 100 to 1 over 100 million on commercializing it. You know, one company, DermTech, hired 150 salespeople after they got Medicare coverage. It was a little sticker that you put on a mole, kind of tear it on and off a few times, mail it into a lab for genetic sequencing to give, you know, should you biopsy it or not to determine whether it's melanoma. What a couple of these tools found out the hard way, they were all focused on dermatologists. And so I think some of the points just made about, you know, the physicians and education and do they want to use it, and there was a lot of pressure even on us early on. Well, why are you going after primary care? Dermatologists, you know, it's a smaller group. They're easier to sell to because they have bigger budgets, they're easier to access. They do high volumes of procedures, right, of skin evaluations, like that should really be your focus. And so we'd learned one of them was already struggling, and then a couple of years later, the other one was struggling. Well, they're already confident in what they do, and they're already skilled at what they do. And there's a really high barrier to get an expert to change how they practice their expertise, right? They view themselves as the expert already, and studies show they are much better. So kind of our philosophy was, and kind of those early discussions, you know, when we were at kind of the seed stage, like he was talking about, of, okay, well, where could this fit and who would actually want to use this where there's not as much friction? Speaking with family doctors and internists, like, oh yeah, skin's tough. I'm often not sure what to do. You know, when it comes to heart disease, diabetes, I'm more confident, right? That's kind of my bread and butter. Skin conditions are not, especially suspicious lesions. So that's where we really saw not near as much kind of resistance and skepticism as like, well, is this really gonna benefit me? I'm already, you know, a specialist or expert in that. There was a real need and interest from those frontline providers for this kind of thing, and they were already aware that. Actually, in our pivotal study at the end, we asked questionnaires, the doctors that involved, what do you believe your sensitivity is for detecting skin cancer? And the most common response was 71 to 80%, like that range. Like they know they're missing a lot of skin cancer, and they know that they could improve. Yeah, our big challenge was, can you actually make a device that not just is high performance, but also low cost, quick, and easy to use? Because if you can't, primary care just from a workflow and a cost standpoint, it's not going to work. And so just to draw a comparison, the genetic testing sticker, the adoption by like 10% of dermatologists within a year. Every dermatologist, because it was free, the little stickers to try. So everyone's like, oh, this is cool new tech, let's try it. the average usage was about 3 lesions per month, which is relatively low because the dermatologist is like, well, the large majority of the time I'm confident what I want to do. I'm an expert in dermatology. And why would I just not do a biopsy? It's clinical gold standard. I'm reimbursed $100 for biopsy procedure. And they had to wait days to get a response, right? Whereas we do it, and so we have some dermatologists. It's mostly derm practices that have MPs and PAs using the device. We just published this at a conference a couple weeks ago. The average use of our device in a derm clinic is 120 lesions a month versus 3. Like night and day. Our average primary care customers are using it about 20 times a month. So what is that, 6 times more than dermatologists use that solution. So I think you gotta kind of figure out the right combination of ease of use and workflow and pricing. But the big differentiator, I think, for us for that was you get a result in 5 seconds versus 3 to 5 days, right? I mean, that was really the big game changer, I think, for us.
Yeah, and I think that's really important to think about, because whenever you, like when I try to call my dermatologist to get in, it's 5-6 months. And so then, by that time, I'm like, nah, I'm just not going. You know, I cancel the appointment.
Yeah. And at health systems, yeah, patient leakage is a big issue. A lot of them, yeah, the wait times, 4 to 6 months, 6 to 8 months. I'm not gonna name names, but one was 12 to 18 months. We're like, whoa. And so now for the first time, they can quantitatively, systematically prioritize high-risk patients. So Baptist Health, who we went live with a couple months ago, they set up an urgent referral pathway for our device. So that for lesions at a score of 8 to 10, so about a 40% chance of being malignant. So the number needed to treat is about, it's 2.5. Those patients get seen within 2 weeks versus 4 to 6 months. And for health systems, like at Duke, some health systems we've spoken with are like, yeah, our PCPs don't refer to their colleagues. Like they don't refer to our own derm department because they know it takes so long. So it was interesting, typically, detect more skin cancer, rule out unnecessary referrals and biopsies, we thought would kind of be the main selling points, and they're powerful. But for health systems that have a lot of access issues and patient leakage issues, like, okay, yeah, those are great. Tell us about this referral prioritization and capability and how it helps with that.
Yeah, nice. Well, we want to open it up to the audience. You sort of have heard Cody's
my spiel.
pitch on DermaSensor, but from your standpoint, do you see this as a benefit? Would you see this as a benefit to your employees? Nods, yeah.
And cancer is, across the board, one of the highest cost drivers for any health plan.
Right.
So,
Yeah.
And someone mentioned something earlier. It's also the #1 cancer killer of young women. I was very surprised to find that out when I went in the field.
Huh.
Yeah.
Yeah. Any questions? Well, we want to thank you. Thank you all for being up here. Is there? Yeah. We have a mic. There we go.
Hey folks, great panel discussion. Thank you so much for being here. As someone who's a little bit earlier in my entrepreneurial journey, only about 1.5 years in, just looking to raise my first round, what advice would you give for, I guess, tuning the amount of risk tolerance? Just a tiny bit of context, I think, while I think it's self-evident that as a venture-backable company, you need to, show a great amount of upside. I wonder how you're even able to diligence, do you think that this founding team stands a fighting chance, even if you know that they're against tough odds? So just kind of curious how, either you've personally framed it, or if you've been on the other side of the table, what sticks out as green flags, red flags? Thank you.
Yeah, I guess I can take the first swing at that. So in the VC world, we look at about 100 companies a week, and from all over the world, and it's really like drinking from the fire hose. So we have to train ourselves to very quickly rule companies out, which sounds a little brutal. But there's lots of different frameworks we use, and keep in mind, we get proven wrong all the time, right? There's times companies we pass on, and those were the extremely innovative ones. So we're not right all the time. But there's lots of frameworks we use to quickly rule companies out, but one framework comes from the PE world, which is private equity world, which is how much margins can a company make, how much cash flows can the company make, because that dictates when the company sells, what valuation multiple would you be able to sell that company for. So I think yesterday I was talking to the gentleman right here that, actually it was the group back there, your revenue model dictates the multiple of valuation. So a SaaS kind of model, subscription as a service, is probably a 10 to 15x multiple. An API kind of service is almost a 20 to 25x multiple. What does that mean is for every dollar of revenue you make, you could sell that company in the future to someone else for about 25 times that $1, so $25, right? So what we do is we take a step back and say, okay, how much money can this company generate? How much margins can it generate at? What multiple of valuation can we use it? And then we do the simple math, is that if we invested in a company at this particular valuation, how much money can we really make? And because an early stage startup, hundreds of things have to go correct for that multiple for us to ever get our return back, because it's a risky business. The VC world is looking for that one hit out of the ballpark, right? That one home run. So we're looking at anything, if it's not even above a 30x kind of return on return, then we have to rule it out, because we're talking about hundreds of things have to go right, and we can't even get a 30x return. Then it doesn't break our thesis. I know there was a second part to your question, but I think that was more to Cody, because you talked on both sides of the table. But yeah.
Yeah, I mean, I think one thing when, the other panels and was speaking with entrepreneurs or aspiring entrepreneurs, I suggest, this is the third health tech device startup I've been a part of launching, the second as co-founder, and I was at Genentech for a few years, but is try to set pretty clear kind of time limits and kind of what you're willing to invest in terms of, your own time, your own money, career opportunity, in achieving, certain milestones, whether it's raising a certain amount or, getting an MVP developed and this initial traction, because it can be really easy to end up having spent years of your life and potentially, sacrificing a fair amount of family time and or financial stability. So I think that's something when you're thinking about your own kind of risk tolerance in the company, like kind of setting milestones definitely provides some cushion. I think things in the medical device world, the kind of rule of thumb, and we've certainly experienced, is whatever plans you make, an estimated cost, double the time, double the cost. We were almost exactly that. And yeah, it's tough creating, especially like a new product category like we've done. It's funny, we tons of coverage around clearance. Forbes, Reuters, Stat, we're on ABC, NBC, CBS, Fox. A few awards at the end of 2024. We're on Time Magazine, Best Inventions of the Year, a Fast Company, the Healthcare Technology Report, Top 100 Health Tech Companies. And everyone's, they're so successful, it's been so successful, that's great. I'm like, it was 9 years. It's not like our valuation's way higher than the amount of money we raised. Like, are we gonna be, we're initially strong commercial traction, but are we gonna end up with thousands of customers within a couple of years as we project? Like, it's a really long and expensive journey just to now have a meaningful shot at commercial success, right? That's what our chairman, after going through the FDA approval process, and you have this limited time frame. So the last couple months were especially intense. I was working 100+ hour weeks. I got shingles during it. And it's like, great, you're through FDA. Now you can start, right? Like, it's kind of like, now's the commercial phase, after it was 8 years. So yeah, I think keep it in mind, okay, what are the the first couple of those steps, like you were speaking about, and making sure for yourself, not just for investors, but for yourself, is this something you maybe want to, dedicate at least 5, 10 to 15 years of your life doing? Yeah.
Can I also say that, on the brokerage side, the employer side, point solution fatigue is real. And there are so many incredible, innovative solutions coming into the market. And we work not only with employers and employees, but also with point solutions and building brand awareness. And what we encourage groups, and I'm not sure what exactly your solution is, but if it is a direct medical device type of solution, your best opportunity to, everybody wants to be inside FedEx and Walmart and serving their employees, and you're in a sea of millions. But when you find cross-channel partners to work with, that's where you really get traction. So the reality of an employer purchasing Cody's product is probably pretty low. It's not, it's right. You're going to need an on-site, near-site clinic, or a direct primary care model, or some other type of model. And so that really eliminates vendor fatigue, because you're now educating through that population or that pipeline that already exists, but you're serving a whole new level and bringing value in a way that wasn't there before.
I'm glad you mentioned that, because I realized I completely forgot to share. So our pricing model, we kind of did a subscription or rental model, because we quickly realized, and we expected this, that it's a very intuitive product. We hear all the time from doctors and patients, oh, this makes so much sense. Why didn't anyone create this before? It's like, well, because it's really hard to create, but and do the multi-year studies and everything. But it's a very intuitive product, right? Like, oh, we heard it compared. People know Star Trek to the tricorder, like the beep 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 beep, like where's the disease, and magic wand for skin cancer, things like that. But for doctors, right? Well, this product has never existed before. So what is it? How is it going to work in my workflow? What are patients going to think? Documentation, reimbursement. So we kind of did this rental model. So it's like, hey, you don't have to buy it, right? You can kind of sign up. So we do. It's those waters have been tough.
Just making sure awake.
So I know, yeah, keeping an eye on it. So it's a 1-year agreement, but so a few $100s a month for like the unlimited use plan, which most do. But they can opt out at 90 days. So we kind of give this risk-free trial period. And that's what we had one clinic at the end of last year that bought a device for $15,000. The other couple hundred have all done this kind of rental model, right? Because they want to learn, experience some of those things before they really commit to this, to the new product category. So,
yeah, thank you. Thank you, everyone, for being up here. As Cheryl Morgan is always trying to provide, solutions that are different, unique, that really help employees, and we're fortunate because we have third-party administrators, we have direct-to-employer clinics, we have individuals like yourself that can really help with utilization. So we can bounce all these ideas off of these people to see, hey, is this even going to be feasible for our employer groups, for the employees in those employer groups? And so we're fortunate to have went through this process with you all. We think it's an awesome solution, really. I think of myself and I think of others that really could use something like this. So anyway, we appreciate it. Thank you all. Thank you all for listening, being here, and we're going to get ready for our next symposium here. Thank you.
Thank you.